this meeting right now. Welcome everyone to the Utah Medicaid July DURB board meeting. A few reminders for our meeting today. If you are dialing in via telephone, Google Meet has muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. We kindly ask that only those who are speaking to the group unmute the device via Google Meet. For DURB board members, please reserve the question until the end of the presentation or ask in the Google Meet chat. For public comment, if you would like to provide public comment, a COI must be on file. Please send an email to medicaidpharmacy@utah.gov. Attendees that are not members of the DURB board, please enter your contact information in the Google Meet chat or send an email to medicaidpharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after the meeting to help us improve our process moving forward. Thank you. And I will leave that to Dr. Cannon. And Dr. Cannon, I just sent out an updated agenda with the public comment request. Thank you.
All right, I think I have the most up-to-date agenda. So if I miss something, let me know. Welcome to everybody for this morning's DURB board. We have a quorum, so we'll call this meeting to order. I don't know, Noon, if we have any introductions. So we will turn it over to you for the housekeeping items. We have immunosuppressants and then the DAW1 override on psychotropic medications.
That would be Jennifer Stroke-Hecker. She would like to speak to the housekeeping item.
Yes, good morning, everyone. I wanted to give an update to the board regarding a legislative report that was submitted in June. And this report satisfied two requests from the legislature regarding some existing statute regarding the preferred drug list. The two areas that we wanted to cover today were outlined. Eric mentioned both the dispenses written override for psychotropic medications as well as immunosuppressants, the carve out of immunosuppressants from the preferred drug list. The purpose of the report was to evaluate the statute and whether or not the statute should be modified and ask the department to report on that. The department did evaluate, and I'd like to just walk through the results of those two outcomes, if I could. The first was looking at the dispenses written override for psychotropics. The background on this is that in 2016, psychotropics were added to the preferred drug list. And with some compromise in putting the psychotropic medications on the preferred drug list, there was a provision to allow a provider to put dispenses written on the face of the prescription. And when that was written on the face of the prescription, the non-preferred prior authorization edit was bypassed so that an individual could receive the non-preferred medicine without needing any prior authorization criteria. So this now has been in place for 7 years. And in that time, of course, we know that the preferred drug list has expanded substantially, and we have a much larger staff managing our overall pharmacy operations. In addition to that, prior authorization is now within the pharmacy team and has been for a number of years. Our average prior authorization time is actually 8 hours to review a prior authorization. And as such, we were able to write a report evaluating the utilization of non-preferred medications as well as the associated cost to the department. And I'll keep it brief because we're certainly happy to provide the report for your review. But essentially what we found is that while non-preferred medications, when they are prescribed for psychotropic classes, and just to specify, the psychotropic classes include anti-anxiety medicines, antidepressants, ADHD medications, antipsychotics, and mood stabilizers, anticonvulsants. So what we found with these medications was that of the time that non-preferred medications were prescribed, 95 in 1 year's time, 95% of the time, these medicines had a DAW1 override on them. Only about 5% of the time was a prior auth submitted on behalf of this. The result, of course, is that the individual did get that medicine without a PA, but the cost of the pharmacy program is substantial. When you look at the cost of a non-preferred medicine versus a preferred medicine in these various classes, it's 200 times more expensive for an individual to get a non-preferred versus a preferred. And before rebates, it cost the program $25 million in 1 year for the prescribing of non-preferred medicines compared to the preferred. So in summary, although non-preferred medicines were only prescribed a portion of the time, a small portion of the time, the associated cost with using these is very, very high. As a result, the department did summarize a list of pros and cons and recommended to the legislature that we seek stakeholder input on whether or not to remove the DAW1 override. And so in 2 weeks ago, we did hold a public comment meeting where we had many behavioral health providers invited to this call, as well as some advocacy organizations. We had 4 outside individuals attend that meeting. There were no behavioral health providers in attendance at that meeting. But I did receive feedback via email from behavioral health providers, but that information was received from that meeting, and the summary report will be submitted back to the legislature. I would like to solicit more input from the behavioral health community, and will be subsequently sending out another email just for written response, just to make sure there was proper notice and proper time for feedback. But overall, we do feel as a pharmacy program that for the majority of the products, we know that we have a robust list of preferred medicines, and they're certainly more cost effective to the state. So we are considering whether we should recommend removing DAW1 override. So that's the one update. The second is on immunosuppressants, and this is a little bit more streamlined of a topic. Years ago, immunosuppressants again were recommended to be carved out of the preferred drug list due to, I think at that time, factors such as expediency of just access for immunosuppressants for individuals receiving, needing an immunosuppressant, receiving a transplant. And they were not included on the preferred drug list at that time. Since that decision was made, again, I think back in I think it was 2015 2016 when the decision was made, there are a number of immunosuppressants now available. We do believe there is an opportunity for some cost savings by putting the immunosuppressants on the preferred drug list, and would like to recommend that we also include those on the preferred drug list. We are reaching out to the transplant providers, both at Intermountain Health as well as the university, to seek their input on this approach. So those are my updates. We're happy to share the report. It is available on our website, but if there's any questions, I'm happy to take those at this time. And I'm sorry, my computer will not start this morning, so that's why I'm on my phone. Apologize for being off camera.
Thank you, Jen. Any questions for Jen from the committee? All right, I think both of those are topics that should definitely be reviewed. I think, as it relates to psychotropic medications, it's a category of drugs dominated by generics, and I think most of the market today uses generics, with the exception of a few brand new branded items. So exciting to see that being discussed, and I'm also supportive of immunosuppressants being included on the PDL. So thank you. That's a good thing for our state to pursue these things. So Everybody should have received a copy of the minutes. Any questions from the committee about the minutes? Any comments? All right. Do we have a motion?
May I propose that we accept the minutes as drafted?
Thanks, Kumar. We have a motion to accept the minutes.
Second.
Thank you, Dr. Turner. We have a second. All in favor? Aye.
Aye.
Aye. Aye.
Any opposed? All right, hearing none. That motion passes. And so we will move on to our conversation about sickle cell disease. And Monet, I see you on camera, so I'm assuming this one's yours.
Yes, it is. Thank you very much. I'm getting over a little bit of a cold, so bear with me. Let me see if I can present really quickly.
And before Dr. Lulo giving the presentation on the sickle cell disease, I would like to go over quickly about the background of choosing the sickle cell disease as a topic for the DUR discussion today. So back in February of this year, the House Bill 487, sickle cell disease, which was sponsored by Representative Sandra Holland, were passed by the legislator to address the sickle cell disease among the residents of the state of Utah. The bill required the Division of Population Health in collaboration with other required within the Department of Health and Human Services, which is including the Medicaid program and the DUR board, and the others division to review and develop recommendations for improving the surveillance, screening, diagnosis, and treatment of sickle cell disease for our residents in the state of Utah. And it's also required the division to report the recommendation to the Health and Human Services Interim Committee. The report will be due next year. Hence the requirement of the bill, we request the assistance from the DRRC to do the review on the sickle cell disease. This likely will be the series topic, which will be this month and also September and potentially October, to further explore the bill requirement on surveillance, screening, and diagnosis of sickle cell disease, and any recommendation from the board to improve the access to care for our residents as well. And with that, Dr. Lulo, thank you.
Yeah, thank you for providing that background to the board. Okay, so good morning, everyone. Today, I will provide an overview of sickle cell disease, treatment options, and barriers to care with a focus on the newest disease-targeted treatments. As Noon mentioned, a follow-up presentation in October will discuss other potential barriers to care. Sickle cell disease, abbreviated SCD, is a rare chronic hereditary hematological disorder that is the result of a single amino acid substitution in the beta globulin subunit of the hemoglobin gene. The abnormal hemoglobin causes erythrocytes to be rigid, adhesive, and sickle-shaped, which reduces their oxygen carrying capacity and functioning. When subjected to hemoglobin deoxygenation, sickle cells are more likely to prematurely hemolysize, polymerize, and vasoocclude compared to unaffected red blood cells, driving the underlying pathophysiologic mechanisms of the clinical manifestations of SCD. Even with treatment advances, individuals with SCD have a life expectancy of approximately 20 years less than the average lifespan for the general population. SCD is characterized by acute and chronic complications that affect most organ systems, as shown in this table. Simultaneous impairment of numerous organ systems can result in multi-organ failure. Although clinical manifestations of SCD differ, most patients experience sickle cell pain crisis, which contribute to approximately 95% of SCD-related hospitalizations. SCD is inherited in an autosomal recessive pattern. SCD genotype depends on the inherited hemoglobinopathy, which plays a role in SCD severity. Affected individuals have either 2 copies of HBS or 1 copy of HBS with another abnormal gene variant. Typically, patients with HBSS or HBS beta 0 thalassemia genotypes, referred to as sickle cell anemia by experts, have a more severe disease phenotype than other genotypes. The 3 most prevalent SCD genotypes are HBSS, HBSC, and HBS beta thalassemia. Although not typically a symptomatic genotype, sickle cell trait occurs in heterozygous carriers with a normal hemoglobin allele and an HBS allele. These individuals can pass the HBS gene to their biological children. SCD is screened for as part of routine newborn screening that is universally conducted across all 50 states, including Utah. Therefore, for children born in the U.S., SCD is most commonly detected shortly after birth. Sickle cell status screening may also be performed in adulthood, particularly for those who want to become or are currently pregnant or postpartum. SCD is diagnosed using a complete blood count with mean corpuscular volume and hemoglobin electrophoresis, high-performance liquid chromatography, or genetic testing, among other tests. SCD can also be diagnosed during prenatal stages using pre-birth diagnostic procedures to assess chromosomal or genetic irregularities in the fetus. Note that diagnostic tests may have limitations regarding which hemoglobin variants they can identify. SCD predominantly occurs in individuals of African or Hispanic descent. Although the exact number of SCD cases in the U.S. is unknown, the current best estimate by the CDC suggests there are approximately 100,000 Americans with SCD. The CDC is addressing SCD surveillance through a state-level, multi-source program aimed at gathering comprehensive health data on individuals affected by SCD to analyze long-term treatment, diagnostic, and accessibility patterns. Currently, the sickle cell data collection program includes 12 states, but Utah is not one of them. There are 4 FDA-approved disease-modifying agents for the treatment of SCD: hydroxyurea, L-glutamine, Valoxator, and crizanlizumab. Hydroxyurea was the first disease-modifying pharmacotherapy to be approved in 1998, followed by L-glutamine in 2017 and Valoxator and crizanlizumab in 2019. These agents differ in several aspects, including labeled indication, approved or age of approved use, and route and or frequency of administration. Hydroxyurea is indicated for patients with sickle cell anemia, which experts refer to as HBSS or HBS beta 0 thalassemia genotypes, but the labeled indication does not explicitly name a particular genotype. Furthermore, although each of these agents are approved for the treatment of SCD, the indicated purpose for use varies among them. Except for Hydroxyurea, which does not provide a specific age for approved use, all agents are labeled for use in adult and pediatric populations. All agents are administered orally on a daily basis except crizanlizumab, which is administered by intravenous infusion. Crizanlizumab must be prepared and administered by a healthcare provider in a healthcare setting. Available disease-targeting pharmacotherapies are not curative, and therefore, patients typically require lifelong treatment. The only FDA-approved curative treatment for SCD is hematopoietic stem cell transplantation, but this procedure can have serious complications. We reviewed 6 U.S. guidelines published by 3 organizations that address disease-modifying pharmacotherapy for SCD. One by the American Thoracic Society, abbreviated ATS, one by the National Heart, Lung, and Blood Institute, abbreviated NHLBI, and 4 by the American Society of Hematology, abbreviated ASH. Most disease-modifying pharmacotherapy recommendations are limited to treatment with hydroxyurea. Both the NHLBI and ATS guidelines predated approval of the newer agents. Each ASH guideline focused on targeted SCD treatment issues such as stem cell transplant or cerebrovascular complications. The NHLBI guideline expert panel advised offering hydroxyurea to pediatric patients with sickle cell anemia, defined as people with HBSS or HBS beta 0 thalassemia genotypes, taking into consideration the patient's preferences and values. Hydroxyurea was also recommended for adults with sickle cell anemia who experience 3 or more moderate to severe sickle cell pain crisis within a 1-year period, have sickle cell associated pain or severe symptomatic chronic anemia that interferes with daily activities and or quality of life, or have a history of recurrent and or severe acute chest syndrome. Additionally, the ATS guidelines strongly recommended hydroxyurea as first-line treatment in children and adults with SCD and increased mortality risk. Notably, the NHLBI guideline emphasized that hydroxyurea may be beneficial and used for other genotypes of SCD based on physician judgment, especially if the patient's daily activities or quality of life are impacted by recurrent sickle cell-related pain. ASH guidelines mention multiple scenarios where hydroxyurea may be a suitable option for certain SCD complications. The ASH guideline on cardiopulmonary and kidney disease highlighted initiating or optimizing disease-modifying pharmacotherapies, including hydroxyurea for patients diagnosed with SCD and pulmonary arterial hypertension. For adults and children with worsening chronic kidney disease-related anemia, ASH suggests a combination treatment strategy involving erythropoiesis-stimulating agents and hydroxyurea instead of hydroxyurea alone. ASH mentions that in specific scenarios where disease-modifying therapies have demonstrated limited effectiveness in managing recurring pain episodes, a trial of monthly blood transfusions may be considered. However, chronic monthly blood transfusions are suggested against as a first-line approach to prevent or alleviate recurrent acute pain episodes. For primary stroke prevention, ASH suggested hydroxyurea as an alternative to regular blood transfusions for select children 2 to 16 years of age with SCD at high risk for stroke. For secondary stroke prevention, regular blood transfusions are recommended for children with SCD genotypes HBSS or HB beta 0 thalassemia. In cases where children are unable to undergo or decline blood transfusions for secondary stroke prevention, the ASH acknowledged that hydroxyurea is an inferior substitute compared to regular blood transfusions, but is superior to no treatment. Generally, patients with SCD should be initiated and optimized on standard of care before proceeding to hematopoietic stem cell transplantation. The exception may be for patients who have a history of overt stroke or abnormal TCD results. ASH guidelines do not provide specific recommendations for L-glutamine, Valoxator, or crenilizumab. However, the most recent ASH guideline from 2021 on stem cell transplantation included L-glutamine and crenilizumab as part of the standard treatment approach for patients with recurrent acute chest syndrome. This guideline noted that patients with persistent recurrent acute chest syndrome, despite optimized standard treatments, or those who have a suboptimal or lack of response to the standard of care, may be evaluated for the possibility of matched related allogenic transplantation. Hydroxyurea is typically considered the standard of care for patients with sickle cell anemia. Given that there is less denoted by genotypes HBSS or HBs beta 0 thalassemia. Given that there is less evidence on the therapeutic utility of hydroxyurea in patients with other SCD genotypes, experts advise using it on a case-by-case basis, weighing the benefits and risks. According to expert opinion, L-glutamine, Valoxator, or crenilizumab may be added to hydroxyurea or may be used as an alternative option if the patient is unresponsive or intolerant to hydroxyurea. Add-on therapy to optimized hydroxyurea with L-glutamine or crenilizumab can be considered for patients who continue to experience vaso-occlusive crisis. Furthermore, add-on therapy with Valoxator may be considered for patients with persistent anemia. No clinical trials have evaluated the efficacy and safety of combination therapy with the newer SCD modulating agents. Theoretically, because all the agents have distinct mechanisms of action, all the agents could be used simultaneously. We reviewed recent literature to identify potential barriers to care with the newer disease-modifying agents. There are several potential barriers to accessing L-glutamine, Valoxator, or crenilizumab for patients with SCD, or for Utah patients with SCD, either with or without Medicaid coverage. A primary barrier is that all 3 agents appear to have insurance challenges, including prior authorization issues and high cost-sharing copays. Additionally, crenalizumab may be slightly less accessible than the oral agents because it must be administered intravenously at a medical facility, and some patients may have transportation barriers. If step therapy with hydroxyurea, the longtime standard of care, is required before using newer agents for SCD, patient or provider resistance to hydroxyurea may translate into delays in receiving one of the newer agents. For example, some patients may be more hesitant to adhere to hydroxyurea than the newer agents because of side effects they have heard of that are associated with chemotherapeutic doses. Therefore, patients should be counseled about the lower dosing of hydroxyurea for SCD relative to chemotherapy and differences in expected side effects. Because Hispanic and African Americans, which tend to be socioeconomically disadvantaged patient populations, are predominantly affected by SCD, preconceived provider perceptions about race, ethnicity, and socioeconomic status may cause patients with SCD to experience disparities in care. Additionally, there is only a limited number of providers that specialize in SCD, and the majority of non-specialized providers lack expertise in managing SCD, including knowledge of treatment guidelines or recommended medications. Cumulatively, these provider-related factors may create barriers to patients accessing recommended treatments. In summary, SCD is a rare chronic hereditary hematological disorder characterized by acute and chronic complications that affect numerous organ systems and can potentially lead to multi-organ failure if left untreated. SCD comprises several genetic hemoglobinopathies that result from the autosomal recessive inheritance of two abnormal beta globulin alleles. Hydroxyurea has been used for decades and is considered the mainstay of SCD treatment, especially among patients with sickle cell anemia, for which it is indicated. There are three newer disease-modifying agents indicated for SCD: L-glutamine, viloxazine, and crenalizumab, which have variable indications for pediatric and adult patients with SCD. Reviewed U.S. guidelines do not provide specific recommendations for the newer agents, but address the use of hydroxyurea, recommending it for adult and pediatric patients with sickle cell anemia and for certain SCD-related complications. There are several potential barriers to patients accessing L-glutamine, viloxazine, or crenalizumab that warrant recognition. Thank you so much for your time and attention. Please let me know if you have any questions.
Thank you. And any questions from the committee? Kumar?
Yeah. So that 100,000 number that you use, is that the average number over some period of time?
That's a good question. Yeah, that's a number that was brought up from the CDC's website of the estimated number of diagnoses that are currently in the U.S.
Oh, currently. So at this moment, that's the number. Okay.
Yes, yeah.
All right. And what about Utah?
That is a great question. We are currently trying to figure that out because there isn't Utah-specific data available on the CDC's website.
Yeah.
But they do have it available for other states.
Right. Say, because it'll be interesting because the population in Utah is kind of a lot different than back east and in California, right?
Yes, yeah.
All right. And because that might give us some more insight into some, treatment that might be more tailored to Utah needs.
Mm-hmm.
Thank you.
All right. Jen, did you have your hand up?
That was my question, Eric. I've wondered about the rate of the prevalence in Utah, and it sounds like we don't know. We'll have to look through our own data and look at some diagnosis codes on the Medicaid side. At least we could evaluate that. Yep. Thank you.
We could also look at newborn screening. I'm just seeing what's published, and it's in 2010 is the data I could find that's published publicly. But we had 126 positive screens in 2010 on newborn screening for trait, but not disease, as we don't have that data. So it's interesting.
I'm sorry, Michelle, what was the rate of that?
We had
220?
126
Uh-huh.
in 2010 of infants with a positive sickle cell
Okay.
trait screen. So probably very small numbers.
All right, Dr. Britton?
Okay, trying to unmute there. Just when I talk to doctors, can you guys hear me okay? But just for you know, FYI stuff, talking to Representative Sandra Hollins this year, she wanted to find out some information about the yearly incidents. So we talked with the hematology folks at primaries. This is about 4 kids a year on average that are positive fractional sickle cell disease. Just you know, not global numbers, not cumulative numbers, but that's about their average.
All right, thank you. All right, we do have some public comment if there aren't any other questions from the committee.
Eric, looks like we also have a comment from Dr. Lim. She's a first public comment. Dr. Lim from the University of Utah Division of Hematology and Hematologic as well.
Yes, I saw the hand and I was kind of waiting to make sure we finished the questions, then we could just move into public comment. So Dr. Lim, we will turn some time over to you. And typically this is a 3-minute period of time, and Brian Larson typically times that, and then the committee may have some questions for you.
Okay, can you hear me okay?
Yes, we can hear you.
Okay. At the University of Utah in the Division of Hematology. And the questions that have been asked so far was the prevalence of sickle cell disease in the state of Utah. And I can tell you that is an intriguing question because I have been trying to figure out this answer for the past 3 years. I can tell you that from what one of the your committee members said, from the primary children's hospital side, they have about 3 to 4 new diagnoses of sickle cell disease per year through the newborn screening. And overall, they have about 45 to 50 pediatric patients currently with sickle cell disease in itself. In the adult setting at the University of Utah, we have about 20. So you can see there's a huge fall in the numbers, and we are not sure where all these patients are going within the state. Either they move out of state because they're now adults, or they are being seen at private practices around the state. I will tell you that I have tried to look for this number through using the Utah hospitalization database that I know available publicly. And what I do is I look through the ER and hospitalizations to look at ICD codes. But you may be aware the problem with using ICD codes is that people miscode it. As Monet demonstrated, there's so many different genotypes, and there's different ICD codes for all of those different genotypes. And there's a lot of miscoding occurring. So we don't have a
Great,
true
thank
accurate
you.
number. I think it'll be good to get that.
All right. No, we appreciate your input there. Did you have other comments for the committee?
No, I'm actually very glad that Representative Holland introduces legislation, because I strongly believe there's a lot more we can do for this marginalized population. Yes, they are very, very small number. I would estimate at max maybe 100 in the state, but that's not mean we should be providing inferior care to them.
Great, thank you. All right, Noon. I think you have a written comment.
Yes, I received a written comment request from Sick Cells, and I would read this to the board while sharing my screen, and Brian will tell me for 3 minutes as well. So dear members of the Utah Utilization Review Board, on behalf of the patients and family with sickle cell disease in Utah, Sick Cells is pleased to submit public comment regarding the drug class review of sickle cell disease agent during the DUR board meeting on July 13, 2023. We write to comment and thanks the Utah DUR board for their past and continued effort to improve the life of Medicaid beneficiary with SCD in the state and recommended that hydroxyurea, Drosia, Skylose, and L-glutamine be added to the state referring drug list with no prior authorization or step therapy requirement. Dose frequency be considered for each therapy when creating utilization management guidelines and approval duration. Hydroxyurea should not be considered a therapeutic alternative to other therapy. We urge the board to recognize that gap in coverage for therapy dose daily that can greatly hinder patient access, and that each therapy work to address a different aspect of the disease and use a different mechanism of action. See the University of Utah DRRC DUR report for more information. SCD is an inherited blood disorder that disproportionately impacts Black and Brown population in the United States, including roughly 1 in 365 Black and African American and 1 in 16,300 Hispanic Americans. It has been an historical underfunded area for research with no new treatment for decades until recently. Atacavio, Oxbryta, and Andari are the first in several decades to advance care for patients and address underlying cause of the disease. The therapy can, in turn, prevent permanent and irreversible medical complications like organ damage and stroke. With over 30 Medicaid beneficiaries with SCD living in Utah, it is crucial each one has access to all FDA-approved drugs so care can be optimized for each individual. Utilization management techniques like prior authorization and step therapy can cause gaps in care and treatment for patients, especially if they are more restrictive than the FDA label, such as current criteria for SCD therapy in 11 states. We thank you for recognizing the importance of this drug class and taking action to help the sickle cell disease community. We are happy to provide insight into the experience of the patient and caregiver community, which should remain central in the decision-making process. Please contact Emma Anderson as EANDEL Delson at sickcellsorg.org for inquiry related to the contents of the letter. Sincerely, Emma Anderson, Senior Program Manager, Sick Cells.
Thank you, Noon. Any other discussion that's needed today from the committee on this? Dr. Weinstein, I see you get your hand raised.
Thank you. I don't have anything specific to say, only that if there's any contribution I can make as this dialogue goes forward. In my early career in New York, I spent the first 8 years in the Bronx, and when I hear this described as a rare disease, it wasn't my experience training up with many patients with sickle cell disease, and the impact of this condition on patients and families to my clinical experience was quite profound. As was noted in the presentation, the excellent presentation this morning, life expectancy is hindered, but the suffering that comes along, and perhaps this is one of the things that influenced me to become a pain medicine doctor. As I'm reflecting, thinking about the children and the adults, the young adults and the older adults that I served during that time in my career. It's heartening to see that there have been advances in therapy because we had very little to offer these patients. So I would urge the committee to take the actions that are needed to get the access to cares remedied for this population. Thank you.
Thank you. All right, Noon, sounds like this is an ongoing dialogue, and so no other discussions needed today. Is that correct?
That's correct, Eric. This will be a series one, and we would appreciate any comment and feedback from the board, how we can improve any utilization or surveillance or diagnosis for this population as required in the bill.
Great, thank you. All right, we will turn it over to you to talk about hormone therapy for gender dysphoria.
Thank you. So this is the hormone therapy for gender dysphoria prior authorization. This is now published on Utah Medicaid website starting on July 1st of this year, so 2 weeks ago. The criteria for approval in adult is patient 18 years of age or older. For gender dysphoria diagnosis, we requiring the persistent, well-documented gender dysphoria or gender inchondrogen, including a marked inchondrogen between one expressed gender and natal gender of at least 6 months in duration. Require the patient to must meet two of the following is marked inchondrogen between one experienced and expressed gender and primary and or secondary sex characteristic, strong desire to read of one primary and or secondary sex characteristic, strong desire for the primary and or secondary sex characteristic of the other gender, strong desire to be or be treated at the other genders, strong conviction that one has the typical feelings and reaction of the other gender. This criteria is followed the SMW5 for gender dysphoria. Additional criteria, the patient must meet one of the following, all of the following: capacity to make a fully informed decision and provide consent for treatment, requirement of minimum of 18 years of age. If significant medical or mental health concern are present, they must be managed accordingly. Can be patient taking medication, seeing a therapist, discussion of risk and benefit and expectation of hormone therapy, documented monitoring plan, male to female, testosterone level for suppression is below upper limit of normal female range, is below 50, and then estradiol level within premenopausal female range, but below supraphysiological level. For female to male, requiring testosterone level to maintain level within the normal male range and avoid supraphysiological level. So these are following the Endocrine Society 2017 guideline for hormone therapy for gender dysphoria. Other applicable preventive screening is cancer, osteoporosis, etc. Criteria for approval in children and adolescents: a patient less than 18 years of age, hormone treatment is prescribed by or in consultation with endocrinologist or physician who is experienced in hormonal therapy treatment in pediatric and adolescent patient. The patient was diagnosed with gender dysphoria before January 28 of 2023. That is a requirement of the SB 16 that was passed in this February by the legislator. Documentation demonstrated that the provider has been treating the patient for gender dysphoria for at least 6 months as well. Documentation demonstrate assessing and treating any physical or mental health if needed. Documentation that the provider have discussed alternative treatment or behavioral intervention for gender dysphoria. The patient had reached tender stage 2 of puberty. If this is the form that they are using to request gonadotropin releasing hormone at puberty blocker. On our website, we also publish a different form for GnRH used for different indication that is not used for gender dysphoria. If the provider requests GnRH for gender dysphoria, they must use this form and meet these criteria for children and adolescents. Documentation of health evaluation by a mental health profession that is different from the provider providing the hormonal transgender treatment. Have a transgender treatment certification, which is a requirement starting January of next year. Have documentation of history of at least 3 therapy sessions with the patient. Have documentation of all mental health diagnosis and any significant life event that may be contributing to the diagnosis of the patient. Have documentation that the patient has persistent, well-documented gender dysphoria and gender inchondrogen, including a marked inchondrogen between one experienced and expressed gender and natal gender of at least 6 months in duration. Must meet 2 of the following: marked inchondrogen between one experienced and expressed gender and primary and or secondary characteristic. Strong desire to rid of one primary and or secondary sex characteristic. strong desire for the primary and or secondary sex characteristic of the other gender, strong desire to be or be treated at the other gender, strong conviction that one has the typical feeling and reaction to the other gender. You submit laboratory value and at baseline before hormonal transgender initiation. Estradiol level in female or testosterone level in male, documented monitoring plan if applicable, male to female testosterone level, estradiol level, and female to male a testosterone level and hematocrit level. Documentation that the provider had discussed with patient and parents or guardian all the following: the reproductive health counseling, risk, benefit, and expectation of hormone therapy and monitor plan, and other applicable preventive screening. Documentation of written consent from the patient and the patient parents or guardian, unless the patient is emancipated. For the re-auth criteria, the provider needs to submit chart note demonstrating the positive clinical response to hormone, reassess of appropriate management of patient mental health status, submit laboratory hormone level and any other relevant monitoring value, such as testosterone and estradiol in male to female, testosterone and hematocrit in female to male. The initial authorization will be up to 6 months and the re-auth will be up to 1 year. This PA was created following the WPATH, the World Professional Association for Gender, the most recent version in 2022, and also the Endocrine Society guideline in 2017, and the American Psychiatric Association Diagnosis and Statistical Manual for Mental Disorder. We also provide the provider with the hormone therapy regimen for gender dysphoria in adult, and notice this is only in adult, as the guideline only having dosing for adult. For estrogen therapy, oral estradiol, we allow up to 6 milligrams a day. For transdermal estradiol PATH is up to 0.2 milligrams a day. Parenteral estradiol valerate or cypionate, they can be giving IM every 2 weeks or 2 to 10 milligram IM every week. For anti-androgen, the Endocrine Society recommends spironolactone up to 300 milligrams a day. For transgender male, for testosterone therapy, the provider can prescribe testosterone, enantate, or cypionate up to 200 milligram IM every 2 weeks or subcutaneous at 50% dose per week. For parenteral undecanoate, it's a non-referred product on our PDL. The provider can be giving to the patient 1,000 milligram initially, followed by an injection at 6 weeks, and then at 12 weeks interval. For transdermal testosterone gel, 1.6% can be used up to 100 milligrams a day. And for transdermal testosterone patch can be giving up to 7.5 milligrams a day. This PA has been shared with the ACOs for awareness as well.
Thank you, Noon. Is there any action required on our part, or are there any comments from the committee?
There will be no action required from the committee. This already been published. We want to share with the board for awareness that this is available for the provider to submit for any hormone therapy requests.
All right, thank you. And any additional comments from the committee? All right, silence is beautiful. We'll continue our day. Thanks to everybody for joining us. We appreciate your contributions. Do we have a motion to adjourn?
I'll move to adjourn.
All right, Dr. Hoffman has motioned to adjourn, and Kumar was a close second, as along with Dr. Weinstein. All in favor? Aye.
Aye.
All right, guys, thank you. We'll catch you at the next meeting on the 10th of August. So thank you. Everybody have a great day.
Thank you.
Thank you.
Thank you.